I welcome you all to this next session. The instruction course 463 is rescue of limbo stem cell deficiency, the stem cell procedures. So this morning we are privileged with renowned speaker, my teacher, Dr. Professor Radhika Tendon. She is a professor in ophthalmology at RP Center AIMS with a wide experience, the teacher of teachers in ophthalmology, and also the experience in handling limbo stem cell deficiency for the past more than 3 decades. So welcome you, ma'am. And next speaker we have Dr. Yogita is there. She is RPC alumni and also now currently assistant professor at Lady Hardinge Medical College, New Delhi. And we have Dr. Abhijit. He is currently senior resident. You please come up in dais. Currently senior resident doing senior residency at RP Center AIMS, New Delhi. So throughout this session, we'll be going through all the challenges in limbo stem cell deficiency and how to rescue them with the different techniques, new procedures, and also we'll show in the few videos also how the procedure is done. So without further ado, I will just start with my first talk, this management of limbo stem cell deficiency. Can you please put on the slides? Yeah, okay. Okay, so I'll be briefing on the management of limbo stem cell deficiency. It will be an overview of all the managements which is done for rescuing the limbo stem cell deficiency. So, starting with limbo stem cells, these are responsible for regeneration of corneal epithelial cells and also the maintenance of the integrity and transparency of the cornea. So we all understand the famous, the French and Taubes XYZ hypothesis, where there is a vertical proliferation of basal cells, and and also subsequently there is a circumferential and then centripetal movement of the cells. That's why, and also the loss of the cells from the surface. So that's how it maintains the transparency, the integrity, the limbo stem cell. That's how it works. So when there's limbo stem cell deficiency, we can see the delayed epithelial wound healing is there, the recurrent epithelial loss and erosion is there, which will ultimately goes to loss of vision. So the etiology of limbo stem cell deficiency is basically divided into genetic and acquired. Genetic is due to the mutation in PAX6 gene mutation, and can be anaerida-related keratopathy, or ectodermal dysplasia is caused by the short arm of 63 mutations. So the acquired cause, it may be of 3 eyes. For easy catch-up, with 3 eyes, eye injury, it can be chemical and thermal burns. Inflammation, it can be mucous membrane pemphigoid, Stevens-Johnson syndrome, and graft versus host disease. And iatrogenic, it can be a limbo stem cells for ocular surface surgery for ocular surface tumor, or it can be pterygium surgeries, or it can be due to topical chemotherapy, which is commonly used as mitomycin for ocular surface comos neoplasia management, and also from some radiation therapy or some from plaque brigade therapy, there can be limbo stem cell deficiency. So knowledge of etiology is important in determining the management of this limbo stem cell deficiency. So coming to diagnosis of limbo stem cell deficiency, about 60% which can be diagnosed by doing a clinical examination, by CT examinations, and rest in some few cases you can consider for impression cytology and in vivo confocal microscopy. So the treating physician should be aware of the limitation of the clinical examination in diagnosing limbo stem cell deficiency, and also perform a diagnosis test whenever possible before undergoing any surgical intervention. So the clinical presentation, it can be abnormal epithelial cells. There can be vascularization of the cornea. The corneal scarring can be there. There can be loss of limbal architecture. The palisade of Vox can be lost, and there can be persistent epithelial defect. When you see on the slit line examination, you can see a fluorescein pull-in, and will be there in the initial partial limbal stem cell deficiency, and in later stage it can be rolling, like a fingerprint roll will be there. In confocal microscope, you can see changes in the basal epithelial cells, which is normally distinct and smaller in size and darker in color. But when it becomes limbal stem cell deficiency is there, you see the cells become more enlarged in size, and the margin become discrete. And in later stage, in the total limbal stem cell deficiency is there, there's maybe vascularization will be there, and the total loss of, and then the deformity of the basal cells is seen. And when we do the impression cytology, you can see a goblet cells over the cornea. So this is one of the things we can identify limbal stem cell deficiency in partially or in minimal case. So the key factor in managing the limbal stem cell deficiency depend upon the severity of the limbal stem cell deficiency. Laterality, whether it's present as unilateral or bilateral, is there any lid and adnexal deformities is there, tear film abnormalities, and also whether the inflammation is controlled or not. So the key milestone in the limbal stem cell biology started way back in 1970, where the epithelial renewal occurs from the limbus, that is known. Then this is followed by the culture of the corneal epithelium, which is understood from 1977. Then the XYZ hypothesis of the limbal stem cells was understood in 1983. Then after that, in 1989, the limbal stem cell resides in basal limbal epithelium. That was known in 1989, followed by limbal transplant after this. The culture of limbal stem cell was started in 1997, followed by the culture of limbal transplant using amniotic membrane in 2001. After that, followed by the cultivated oculomucous epithelial transplantation was seen in 2004. The famous SLAT, the simple limbal epithelial transplantation, which was described here by Sangwan et al. And also was popularized more over in our country, was done in 2012. And after in 2013, so far, the allo SLAT also has started. So treatment option of limbal stem cell deficiency, we have varieties of treatment options, starting from the eye lubrications, the autologous serum, the corneal scrapping, and also soft contact lens or scleral contact lens, and various stem cells transplantations like SLAT, the COMET, AMT, the CLAL, and congenital limbal autograft, ex vivo cultured, cultivated limbal cells, keratolimbal allograft. So all the varieties of options are there, but we have to be very judicious and see which option will be best for which type of patients. So for this one, the simple algorithm is that the management of limbal stem cells, if it is total, we can see whether visual axis is affected or not. If there is no visual axis affected, then we can consider for topical lubrications. If affected or visual axis is there, we have to check whether the adnexal is involvement or not, the lead abnormalities is involvement or not. If there is, then correction of this abnormalities is first. And if there is no lead abnormalities, we may consider whether it's unilateral or bilateral presentations. So if it is unilateral presentations, then stem cell therapies is a good indications. It can be autologous or allogenic. The autologous can be CLAD or SLAT or COMET. The allogenic is limb-related congenital limbal allograft, or it may be keratolimbal allograft. When it's a bilateral, it may be, we have to check whether ocular surface is dry or wet. If it is wet, the keratoprosthesis, Boston type 1 keratoprosthesis is a good option, or dry, also type 2 can be used. Then if it is wet, in bilateral cases, you can consider for stem cell therapies, various stem cell therapies. So here's one case scenario, case of ocular surface squamous neoplasia, very well settled there, and after post 2 months of interferon alpha 2 beta, that you see all that squamous neoplasia has vanished. But now the concern is there's limbal stem cell deficiency is there. So what to do for that? So in such scenario, we have to first check the impression cytology, check whether there is any abnormal atypical cells are still there or not. We have to check first. Then after that, we can consider for this patient, this is a unilateral case, so these are the ideal case for the simple limbal epithelial transplantations. So studies by Dr. Swati Kaliki and Virendra Sangwan et al. Have shown that concomitant simple limbal epithelial transplant after excision of ocular surface has shown a very good result, where if there is only the excision of the OSSN, then there is found to be around 75% of limbal stem cell deficiency versus 0% if there is concomitant limbal stem cell transplant is done. So it has shown that the concomitant primary simple limbal epithelial transplant after excision of the oscillation can prevent the LCD cases in case of extensive involvement of OSSN. So next is for severe and unilateral or bilateral limbal stem cell deficiency. Here's a new procedure by Cincinnati procedure, which they use the living-related congenital limbal allogenic graft along with keratolimbal allograft, which have shown around 70% has shown the vision improvement is there, and also the keratoprosthesis is shown a very good result after this procedure. So the ocular transplant with combined living-related cloud versus keratolimbal allogenic graft and stage keratoplasty has been an effective procedure to improve visual acuity in these patients, and also keratoprosthesis also do show a promising result. So just to summarize the principles of the autologous stem cell transplant. So it can be congenital limbal autograft. The details is what it does here is that the conjunctiva and the limbal tissue is harvested from the contralateral eye and is directly transplanted into recipient eye. So it can be used only for unilateral limbal stem cell deficiency. Next is CLAD. CLAD can be autologous. This is ex vivo cultivated limbal stem cells, where you harvest from the contralateral eyes, and that ex vivo culture is stage procedure. And the limitation is that it may be required a stem cell lab is required, a current general management practice is required here, and it requires a small preserved limbal stem cell tissue is required here. Next is SLAD, may be considered for bilateral limbal stem cell, that the limitation is there. And for COMAT, their epithelial cell is harvested from the mucosa and ex vivo cultured, and is expanded there, and it can be transferred to the recipient bed. For allogenic graft stem cells, we have got the CLAD allogenic, which is harvested from living donor or cadaver. CLAL is the living-related congenital limbal allograft. And we have the keratolimbal allograft. The cadaveric is harvested from the cadaveric donors, where the limitation is that you need an immunosuppressive drugs, and that there's a risk of rejection and the failure rate is high. You have the Cincinnati procedure, which I have already explained before, and modified Cincinnati, where conjunctival limbal allogenic graft along with the keratolimbal allogenic graft can be used, which can be harvested and cultured, and then the cells is the cultivated cell is used in a recipient eye, deceased eye. But here the limitation is that here also required an immunosuppression, and the risk of rejection and failure rate is high is there. So in conclusion, the management of limbal stem cells still remain challenging. However, in spite of many medical and surgical options which are available to rehabilitate the ocular surface, the successful outcome can be achieved in majority of cases by judiciously selecting the appropriate treatment procedures. So I would like to acknowledge my teachers and my colleagues here, and also the ORBOS, the stem cell facilities at AIMS, which providing this stem cell facility. Thank you all for your kind attention.
Thank you very much, Dr. Lomi. Nicely covered the full range of management options for limbal stem cell deficiency. Next, we will go ahead with the talk which was supposed to be given by Dr. Vanati. She's busy in another session. So Dr. Abhijit Peniwal will be giving the lecture. He's from RP Center AIMS, from the Cornea Refractive Surgery Unit. Simple limbal epithelial transplant, SLET. Tips and tricks.
So, good morning everyone. I'll be giving my talk on tips and tricks of simple limbal epithelial transplantation. No financial interest. Going briefly into history, already it has been discussed, but several techniques of stem cell transplantation have evolved over time. Conjunctival limbal autografting was first introduced in 1989, but it led to large areas of stem cells being removed from healthy eye and led to iatrogenic stem cell deficiency. So in 1997, cultivated limbal epithelial transplantation was introduced. In this, a small lenticule was removed from healthy eye. It was grown in laboratory, but it still needed sophisticated laboratory. So in 2012, Sangwan et al. Came up with in vivo growth of stem cells, that is simple limbal epithelial transplantation. So these steps I'll be discussing in my video courtesy Professor M. Vanti. So we mark around 4 mm area, preferably in superior limbus, and we cut with a blade both on the conjunctival and on the corneal side. We want to include a part of stem cell, and several techniques have been described, but here we have cut with blade and we'll dissect. Blunt dissection is carried out using the crescent blade, and it is cut using Vanna scissor, and it is stored. So this is the diseased eye, and you can see there is no symblepharon, and we'll do 360-degree peritomy and achieve hemostasis. Then we'll do some pannus removal is done, and you can see there is total hemostasis. Then amniotic membrane is put with basement membrane side up so that it sticks well, and it is trimmed to the size, and no folded areas are there. Now the lenticule is put over it. It is cut into several pieces. The pieces should not be placed in the visual axis and should not be placed as limbus either. They are placed slightly inside. If placed at limbus, that may lead to long-term scarring or a visual axis. So they are placed all around. They are placed epithelial side up, which can be seen. The white side is the stromal side. So epithelial side up, we try to place, although the stem cells will find their niche even if placed other way around, but we try to place them epithelial side up. So they are placed all around, and fibrin glue is applied then to secure them. So, and then a bandage contact lens is put. In children, we can even do tarsorrhaphy so that they don't rub the eye. Some other steps I would like to say. So firstly, we prefer superior limbus because it is said to have more stem cells. And secondly, if the diseased eye has symblepharon, we can go with conjunctival autograft along with the slit procedure. So that is one, and the eye should not be inflamed. We have to make sure that eye is not inflamed, the inflammation is under control. And post-op, we give prednisolone acetate drop in the diseased eye. Some people prefer to give prednisolone in the normal eye also, in which lenticule has been removed, but we usually don't give it. And since it is autologous, so the steroids can be stopped after some time. That is the advantage. So several studies have proven superiority of this procedure. Sangwan et al. In their pioneer work, they reported successful primary outcome procedure defined as completely epithelialized, avascular, and stable corneal surface at 6 weeks in all 6 patients. And best criteria visual acuity improved to 20/40 or better in 4 eyes. Basu et al. Reported 2/3 of successful cases attained 20/60 better vision, and over 70% children showed complete epithelialization. And Gupta et al. Reported anatomical success in 80% and functional success in 85% of patients. It has also shown successful result in case of previously failed clot and have shown to a better outcome than repeat clot in such patients. And it improves outcome of sequential keratoplasties as shown by study by Deepti Singh et al. It reported anatomical success 72% of eye, visual acuity, improvement in over half of the eyes which underwent DALK post-slit. And there are several modifications described. Amesco et al. Described the use of double-layered AMG in which limbal stem cells could be sandwiched between the two layers. And Vajrani et al. Reported customized slit. They first did slit in a patient. It led to improvement of ocular surface. It then led to another mini slit which was applied to bare corneal surface with fibrin glue. In the second step, they did not use amniotic membrane. Kalki et al. Explored the concomitant slit with excision of pterygium, and mini slit has been described for treatment of pterygium by Bongetes et al. And Maligan et al. Proposed glueless slit. In this, limbal stem cell explant were inserted in short oblique tunnels in corneal periphery, followed by placement of amniotic membrane on top. Thank you. Any questions?
Thank you, Abhijit. That was a wonderful talk. In your once result, you have shown that the limbal stem cells that have been harvested and then placed over the cornea directly, and one study have shown that over the empty membrane graft. So, is there any randomized studies was done between this one, or what is your take on it?
So, amniotic membrane provides a substrate for epithelial growth. So, ideally, it should be used. In the study in which they did not use, they have already already improved the ocular surface once with amniotic membrane. So, ideally, amniotic membrane provides substrate, and it is shown that slit is a true regenerative procedure because the stem cell marker ABCG2 has been noted after surgery, like 6 months after surgery, it has been noted. So it is a true regenerative procedure which led to introduction. It not only epithelializes, it leads to introduction of stem cells which stays there. So ideally it should be used with amniotic membrane.
Yeah. Okay, thank you. Yes, please.
It will stick better if the stromal side is down. Otherwise, even if not done, then it is rough. The stromal side would be a bit rough. Basement membrane side will be
You can use a cotton
smoother.
swab, wet cotton swab, and place over the amniotic membrane. If stick, then it is stromal side. And usually the epithelial side is smooth. It doesn't stick it. Yeah.
So the stromal side will stick better, it is said, though it will not come out. We did put glue in below that. We should do because because most of these patients are children, they may rub eyes. So it's better to suture around also, and we can put glue also. In this case also, I have edited that step. The glue was put beneath it also. Yeah, so with the crescent blade, the pannus was removed a bit. Okay, partial keratectomy was done to raw the surface.
Thank you, Abhijit.
Thank you.
So we'll go to next speaker. I invite Professor Radhika Tandon. She will be speaking on the role and outcome of stem cell therapy for limbal stem cell deficiency, followed by her next talk on COMET and COSET. Yeah.
Thank you so much. Good morning, everyone. So, in a way, we've had a whole range of history from past to present, and we've also had experience of, getting reports and publications from all over the world. But you have to adapt on what's available to you. So I just like to give you an overview with that perspective. So if you see as etiology, as Dr. Lomi nicely said, there are a whole variety. So it's largely a clinical diagnosis. Definitely impression cytology is a help, but with the past experience of publications and research, you do know that it correlates. So you don't have to do the impression cytology for every case. It's only if there's doubtful cases, if you're doing some study or you want to prove something in a research protocol. So these are largely the clinical features, and the patient will have vision discomfort and conjunctivalization. However, the problem comes if you go strictly by this. Sometimes a patient will have these features, but the cells are quite healthy in a way, as I'll show you with some examples. So there are these classical features with opacification. There's a disruption of the palisades of Vogt. The other thing to look for is whether there's active inflammation. When talking about impression cytology, again, it's not something which will be accessible to everybody. You'll have to have a laboratory, and you'll have to have a pathologist who's cognizant with it. So if supposing there is any need for anybody to verify, then you can make a kind of a marking on the filter paper strip that you have, so that when you send it to the lab, they will know which part of the filter paper is indicating which side. So you have the cornea, you have the limbus, and you have the conjunctiva. And when you have patients with very extensive damage like Stevens-Johnson syndrome and so on, you must take a separate piece from the, specimen from the conjunctiva, because sometimes it's so severe that there is no goblet cells even in the conjunctiva, particularly in Stevens-Johnson syndrome or inflammatory dry eye. So then you'll falsely get negative on the cornea, and you may wonder about it. So unilateral, bilateral, and also look at the vision and whether the patient is comfortable or not. So here we would look at the various the classification systems that you have, and then when you come to the management, don't forget that you have to restore the ocular surface. Often the patient is very anxious, very keen to go for immediate restoration, but you have to explain that the stem cells, when transplanted, they require a stable and a healthy ocular surface. So you require a healthy soil, which is a substrate. There should be no active inflammation. There should be adequate tears and a healthy epithelium, and so on. So this is the customized approach, and Dr. Lomi had nicely said, don't forget that there is an option of a conservative do-nothing approach, because just as we have said that the stem cells regenerate on the surface, similarly, the patient's own hematopoietic stem cells, they may replenish the limbus and they may improve the situation later on. So it's worthwhile watching for a while. Now, when you have a case of conjunctival limbal autograft, as Dr. Lomi said, you can also combine it with an adjuvant amniotic membrane if there is an associated symblefron. And even a living-related conjunctival allograft can work in such situations. For example, if there's a bilateral deficiency. But when you have when you're taking an allograft, you must use a pretty heavy immunosuppression. So you'll have to use oral steroids and very heavy topical steroids as well. But this is an example that with proper meticulous care, even a live-related autologous, live-related allograft can work. The trouble with these is that you can have rejection, so you do have to watch very carefully, and there is clinical improvement both in vision, patient comfort, and corneal clarity. The other option is a cadaveric stem cell graft. Here you can either apply it in the form of a lenticule. So here you are not removing the epithelium on the ocular surface. It takes a little bit more time. But on the other hand, you're not exposing the entire cornea to a raw surface. And also sometimes if the cornea is thin and you expose it to a raw surface, it tends to undergo melting. So this can be done for a donor rim. If that is done, then you can use an age less than 40 years, as fresh a tissue as possible. But it does require systemic immunosuppression. So these are examples of cadaveric limbal stem cell transplant. And the variation has been said that if the condition is so bad, initially you do this, and when it improves to some extent, then the further step can be topped up with a sledge procedure. This is an example. Sometimes you get excellent results and sometimes not so. So this is the limbal stem cell allograft. As you can see, the pictures are quite encouraging. This is an example of a 6 months comparison of the conjunctival allograft versus a keratolimbal allograft. So what is the difference? Conjunctival allograft will be taken from a living relative, which is a fresh tissue, and a keratolimbal is taking from a cadaver tissue. There you have to take a little bit more deeper, because the stem cells require to have what they call as their comfort zone, and they require the cell-cell interaction to be given an encouragement management to grow. And if you have a very severe case, a monocular patient, you can even do an annular corneoscleral allograft, which has been done like this. And a large diameter LK is what we recommend if you have a thin cornea, because when you have a cornea where after removing the pannus there's going to be less than 300 microns, then that cornea is too thin and it tends to melt. So if you want to do a one-stage procedure, you can do a large LK, so a younger donor where you include the limbus and you suture it in. And then if later it does fail, you can do a simple penetrating keratoplasty later on. So these are a few examples of large LK. So large lamellar keratoplasty, this is useful if you have a thin cornea. Now, when you talk about cultured limbal stem cells, here again, there are several techniques of culturing. You have variations where you have the suspension culture, but we had to see that in our conditions, what can be the locally adaptive methods. So in a sort of low resource setting. So we have cultured them using amniotic membrane, and then after confirming in the lab that the cells and the technique was adequate, then we proceeded to the patient. But there is one drawback of this procedure, that you're not verifying the stem cell each and every time. So you have to first standardize your method, confirm that what protocol you're following is doing what it is supposed to do, and then follow that protocol strictly later on. So this was a kind of a criticism of this procedure when it was considered that it could be when you could go for DCGI approval and make it as a kind of a standard accepted procedure. This was a criticism. So they said, no, you have to prove it by an RCT. And then, of course, when you have failures, you can look at causes. It could be inflammation, it could be secondary infection, or it could be a rejection. If you have an acute rejection, this is only with allografts, then you can have instant pain, redness, photophobia, and then you'll have edema of the lenticules, and of course epithelial defects, myopia is treated with topical steroids and sometimes even systemic steroids. So now, what about the long-term success? So everybody would have individual photos. Some are doing well, some are not doing well. So what can we tell the patient to expect or the family to expect? So there's a wide variation. What are the strategies? Of course, it will depend, because different cases would have different individual concerns. Sometimes there may simply be non-compliance to treatment. The patient may have just stopped the treatment or not use it regularly because of side complications or because of affordability. So therefore, we did a systematic review of what are the outcomes of various surgical interventions for the treatment of limbal stem cell deficiency. And unfortunately, there are no RCTs. But based on the large case series, etc., available, just look that all the procedures have reasonably good anatomical success rate. So that's in a way good news. So whichever surgeon has whatever access or whatever the comfort zone, you can do any of these procedures. And the gain with visual acuity was better with SLET and keratolimbal allografts than with CLET. But here again, there could be variations in case selection. So that is something you have to remember when you do a systematic review like this, and particularly when there was no standardized RCT. And here, giving you an example of a direct lenticule, limbal lenticule, which is applied. And as you can understand, it will take time for this lenticule to expand. And initially, the criticism of this was that you would have to use a larger, as Abhijit also said, take a larger piece. So in order to standardize this, in our RCT, we took the same size piece. So this is, I would like to acknowledge the contributions of the stem cell laboratory at AIIMS and the funding we got for the Department of Biotechnology. So with that, I'll go to the next slide, the next one. So in a nutshell, I will say that you can be confident of doing whichever procedure is accessible to you, just keeping these principles in mind. Now, what happens when you have a bilateral case? So bilateral cases are challenging. We do have an option of live related, but autologous is always better because these patients are quite sick and you want to avoid using systemic immunosuppression. And in our patient population, even that systemic immunosuppression is expensive. So we have done a comparative evaluation of cultivated oral mucosal autologous and also cultivated conjunctival. So just like you have stem cells at the limbus, there are also conjunctival stem cells deep in the fornix. So the objective is to evaluate the efficacy of transplantation of cultivated oral and cultivated conjunctival epithelial cells, look at the efficacy and safety. And since there was a shortage of RCTs for unilateral stem cell deficiency, we also incorporated a pilot RCT, a limited RCT is this over for one talk or second talk? Second talk also time over? Okay, so just remove, okay. to evaluate and compare the efficacy of direct limbal lenticule with SLET and CLET in patients with unilateral limbal stem cell deficiency. So in vitro culture, we do require a CGMP lab. We do not have a certified CGMP lab at AIIMS, but we have a CGMP compliant lab. And the basic, it works that in the OT, the tissue is harvested and put into the transport medium, and then it is transferred to the lab and grown. And they were randomized to develop, to receive either conjunctival cells or the oral mucosa. And for the unilateral cases, the direct limbal and SLET were done by the surgeon himself in the OT, and the cultivated group went to the lab. One change we did is, I thought that with the microscope and the surgeon having so much of expertise, and similarly in the lab, there is another person who's a non-surgeon who's cutting it up into pieces and transplanting it. So I thought it'll be good to validate if you have a pre-chopped versus an intact piece. So the lab would be given 2 specimens. So whatever piece we would take, we would break it in half, cut it in half. One half the surgeon would split into those 8 to 10 to 12 explants, and the other would be left to the lab. And we just wanted to see how they would fare. We looked at the unilateral cases, DLT, SLET, and CLET, and in our experience, they were equally good. And in the case of characterization of the cultivated limbal epithelial cells, they met the criteria. The only thing we found is that somehow the lab felt more comfortable with the intact pieces, and they felt that they had a higher growth rate and a quicker growth rate. So it's possible that the cells, the process of chopping is making multiple cuts, and in the process of going to the lab, and they're usually processed the same day, it's possible that that is producing some kind of an irritation, and the cells are, they would count the pieces, whereas when it's intact in the lab, it's done fresh. So this is something that's still work in progress. And again, it will depend upon the expertise of the person in the lab. So if supposing that that person is not comfortable doing it on their own, then the surgeon can cut the pieces and send. Though of course now CLET is completely phased out, and it has been completely overtaken by SLET. But this is just to give a validation for the process. And then these are representative AIOCT images after longer follow-up, and as you can see, they are all comparable. And for the bilateral cases, comparing COMET versus COSET, here we found that these were all cases with bilateral Stevens-Johnson syndrome or chemical burns. There were very few patients of chemical burn, only 2 or 3. Largely, they were Stevens-Johnson syndrome. So here, we found that the oral mucosa grew better, and there was at least 4 patients where the conjunctival cells did not grow at all. So therefore, I would say COMET is a better procedure. Our thought process was that COMET has been described to show vascularization, and maybe the conjunctival epithelial transplant would do better. However, in a head-to-head comparison, the ones which grew, there was no difference. So therefore, I would say that COMET is a good option. And then the representative AIOCT and post-op pictures. And the standard quality control checks that were done. And so the research leads were that unilateral cases, all 3 are good. So SLET is a very, very good procedure, and the research leads along with scientific relevance of our bilateral cases showed that pre-chopped versus chopped, the intact ones were better. And you can see the outcomes for COMET as well as COSET. They are also good with improvement in the ocular surface as well as vision. And here it also improves with time, but it's extremely important to also monitor what are the compliance with the post-op medication. So these are examples of the H&E staining, as well as the scanning electron microscopy and the immunohistochemistry to show that the quality of the cells is as expected. And the BCVA in DLT, SLET, and CLET groups, all of them improved. So with that, I would say that there's a definite role of limbal stem cell transplantation, and we had taken patients who had already gone through a long process and they had not shown any further improvement. Regarding your choice of treatment, I would say SLET is a good option, and in case of an acute burn, that's another discussion, but in acute burn, the team led by Geeta Iyer has shown that you can combine amniotic membrane with an allo-SLET for acute burns, because you don't want to sacrifice the tissue you've taken from the other healthy eye. So this is again a validation of all those concepts. Thank you very much.
Thank you, ma'am. That was a wonderful insight from this new technique, the COMET and COSAT. If there is any question to ask for ma'am, if there is some, yes, ma'am. I would like to know, like, for this COMET, your culture, cultivated in the lab. So how long, after how long we can use the cell used to grow? And number two is, if that growth, the culture, if we use it and then if some are left behind, can we reuse it later on if for the same patient, if we can reuse it and save in the iBank, or we can use it or not? That.
Yes. So, good questions. One is, generally it is described to take up to 3 weeks, but in our experience, it's always grown within 2 weeks. So within 2 to 3 days, you can see the explants. So when they, in the lab, they put the cells to culture, they leave it in the medium for 48 hours without disturbing it because they want to stick. And after 48 hours, they check, and you invariably start seeing the outgrowths. And by 2 weeks, you have a confluent layer. It is described as up to 3 weeks, but generally maybe the conditions that we have, so you can schedule your case electively at 2 weeks. You do the harvesting and you schedule the case after 2 weeks. In some of the cases, the first time we found that cells did not grow was in the COSET. So that was a new learning. So in that case, you have to warn the patient. Secondly, that if you have transplanted it, and can you keep another backup? So in this study, we had two. Each patient had 2 cultures. One was the intact and the other one was the one where the pre-chopped was sent. But traditionally, people don't take 2 pieces because they only grow in 1 sheet. So once you have taken the sheet and applied it in the lab, then, in the OT, then you cannot leave that residue back into culture. So you cannot save it in the lab and all, because it has to be, it's an ex vivo growth, and it's considered as maximum manipulation of cells outside the human body. So therefore, you don't know what's going to happen to the cells, so therefore it's not recommended that you keep it and save it for a later date.
Thank you, ma'am. And is there any preparation for the patient, for the particular patient to harvest from the oral mucosa?
Yes.
They need anything?
Important question. So yes, you have to prep the patient, check their oral hygiene, and they start using betadine or chlorhexidine gargles 3 days before, and after the procedure also that continues. So 3 days they start, and then a local treatment with betadine, and then harvesting. It's a very superficial harvesting that's done, and you don't need to suture it. It just heals very, very easily. And avoid hot food after it, hot and spicy food. And I've never had any patient complaining of mouth ulcers or any discomfort.
Thank you so much, ma'am. With that, we'll go to the next speaker, Dr. Yogita. She is assistant professor in Lady Harding, New Delhi, RPC alumni. She will be speaking on the cultivated limbal epithelial transplantation.
Good morning, everyone. So, overview of my talk, I'll first introduce about the cultivated limbal epithelial transplant technique, describe its surgical technique, discuss its role in limbal stem cell deficiency patients, and I'll then talk about the management outcomes of CLET in LSCD eyes and then our experience. Cultivated limbal epithelial transplant was first reported by Pellegrini in 1997. As discussed, it is an ex vivo expansion of cells to obtain a cultured sheet of human limbal epithelial cells in the lab. And this sheet is then transplanted onto the limbal stem deficient cornea. It can be an autologous or an allograft. It is best suited procedure for unilateral total limbal stem cell deficiency. Essentially, a 1 to 2 mm of healthy limbus is harvested from the healthy eye and expanded in lab. This procedure allows the implant of a larger size in the recipient eye. It saves the donor cells in the case there is need for a second intervention. The drawback being that there is a requirement for a lab setup to cultivate the stem cells. It is a 2-stage procedure. So this is a schematic diagram where step A shows a limbal tissue excision, specimen being taken. The specimen should include the limbal palisades of Vogt. Then figure B shows the specimen placed onto an amniotic membrane graft for allowing the limbal epithelial cells to expand in an explant culture system. Here AMG acts as substrate and a carrier for cultured cells, and the culture media provides the nutrients and mitogens for its growth. The figure D shows excision of the fibrovascular pannus for preparing the recipient eye, and in E you can see the finally placed explant onto the cornea. Between the donor and the recipient eye, this step of cultivating the limbal stem cells requires a CGMP lab. So preoperative considerations are any dry eye disease or a meibomian gland dysfunction should be treated before surgery. Correction of entropion, ectropion or trichiasis on any corneal exposure should be dealt with before going for surgery. Fornix reconstruction procedures are also advised before any ocular surface reconstruction. You should also treat any active inflammation prior to surgery. It's also a good idea to assess the corneal thickness pre-op so that if a concurrent lamellar or penetrating keratoplasty is required in thin corneas, that can be performed. I'll be showing the video of cleft surgery. Video courtesy is Professor Dr. Radhika Tandon. So here we are marking 4 millimeters extent from limbus, giving a subconjunctival injection, then excising 1 millimeters into the cornea so that we obtain maximum palisades. We're using Vana scissors here and then a crescent knife for a dissection. This specimen is then sent to the lab for growing the limbal stem cells onto the amniotic membrane graft. So this is the biopsy specimen. Now this is the recipient eye. Here we are dissecting the fibrovascular pannus, doing a peritomy 360 degree. Often extensive cutting of the fibrovascular pannus is required in these eyes, and sometimes even speculum cannot be placed easily. Here the symblepharon release can be seen, and then hemostasis is achieved. Further dissection and finer dissection using a crescent blade. This is the cleft received explant from the lab after 3 weeks. The cells have been grown on an amniotic membrane, and this is how we have received it from the lab. We are finally placing the amnion membrane on the recipient eye. Using a fibrin blue, we are securing this membrane graft. It can also be done using a vicryl sutures 80. So in one half we have placed the fibrin glue, and now the other half. And then finally trimming and shortening of the amnion membrane. Alternatively, as ma'am has just discussed, we can also divide the pieces before we give to the lab. And a bandage contact lens is placed at the end. For mechanical protection of the graft, we can also perform a tarsography, especially in pediatric patients. Post-op, we should give antibiotics for prophylaxis against infections. Topical steroids are started immediately, and because it is an allograft, because it is an autologous graft, we can stop the steroids early. Topical immunosuppressants like cyclosporin A and tacrolimus ointment are also used. Sometimes oral steroids are required to control inflammation and to avoid allograft rejection. Advantages of CLED is it minimizes the donor eye limbal stem cell deficiency. It provides a good yield which can be confirmed in lab by ex vivo expansion of limbal cells, and long-term cryopreservation theoretically is possible. Disadvantage is that it is a costly technique and requires a current good manufacturing practices compliant lab. Role of SCLET in LSCD is that in LSCD there is a destruction of stromal niche of cells. So this is a cell therapy where the cultured limbal epithelial stem cell sheets is reintegrating into the recipient eye's limbal stem cell niche. There is no RCT to compare the different surgical techniques. However, there is a systematic review published in British Journal of Ophthalmology, and existing evidence say that SLATE and conjunctival limbal autograft techniques are having a better anatomical and surgical outcomes than CLET. This is another systematic review published in Indian Journal of Medical Research by our team, and here we have reviewed 1133 abstracts, and finally 17 studies were eligible. Here we have reviewed different types of retrospective and prospective studies which were done to evaluate and compare different techniques of limbal stem cell transplantation. So in the prospective techniques, one performed at our institute, here you can see this is done in 20 eyes to compare the conjunctival limbal autograft, the conjunctival limbal allograft, and the keratolimbal allograft. And then another study by Parihar et al. Comparing the CLET with CLAL. Now, in the retrospective study, the biggest set of patients is by Sangwan et al., who have performed CLET in 200 eyes. Success rate of CLET is reported to vary from 30 to 100%. And here in this particular paper, which I just mentioned, the 200 eyes were treated with CLET with the mean follow-up of 3 years. Primary outcome was 71% success. That is a stable ocular surface at 1 year. And secondary outcomes were of CLET, 2-line improvement in BCVA. In 60.5% of eyes, at final follow-up, 40% of eyes had a vision better than 20 by 60. 27% eyes had vision between 70 by 70 and 20 by 200. 33% eyes had vision worse than 20 by 200. And 4% had corneal scarring, and recurrence was seen in 29%. This is an image of our experience with CLET. This is the right eye normal eye, donor site, and the other eye showing a post-chemical injury sequelae, a preoperative image, and then finally after 1 year, the donor site was intact. And you can see improvement of the ocular surface after 1 year of CLET. This is another image. And then in this particular patient, CLET was combined with a lamellar keratoplasty to improve the ocular surface. To summarize, CLET is an effective 2-stage stem cell therapy. It is best suited for unilateral limbal stem cell deficient eyes. It has good anatomical and functional outcomes with the advantage of requirement of a small limbal specimen. It's a costly procedure with a CGMP lab requirement. I acknowledge the help of my cornea and ocular surface gurus, Dr. Radhika and Lomi sir here, and Dr. Vanati and Dr. Nupur Gupta. Also, the help received from in charge of stem cell facility, Professor Sujata Mohanty, and DBT Center of Excellence Project for Ocular Surface Reconstruction with PI is Dr. Radhika Tandon. Thank you for your kind attention.
Thank you very much, Yogita. So you nicely covered the literature as well as the information available for CLET. Just 2 points for the audience. The purpose of this talk was to give you a full range. This instruction was to give you a full range of options. So if you have a patient with such severe symblepharon as shown in Yogita's case, there, you can do, if you don't have the facility for a lab and you don't perhaps want to sacrifice a SLET, because SLET may be difficult in such a case straight away because you're not very sure how the surgery itself will produce inflammation, and it's you don't know which way the patient is going to go. So in this case, you can either do a live-related allograft or you can do a keratolimbal allograft, let the eye stabilize, and then later you can take it forward. That was the only purpose of showing you the entire range of procedures. And there was a discussion about amniotic membrane and glue. So again, we have shown in the lab, we have tried all the options, growing on this side, growing on that side. So the stromal side has the matrix with all the good proteins, etc. So that should be on the touching the ocular surface. And the epithelial basement surface is the one which is smooth, and it helps the cells to grow, spread out better. So therefore, ideally, and as Dr. Lomi said, the stromal side is more sticky and it looks a little like vitreous jelly. And also the dry amniotic membrane, we have not tested all this with the dry amniotic membrane. So it is the wet amniotic membrane that you should be using. The frozen amniotic membrane are kept at -80 and not the dry one. Okay, so with that, Dr. Lomi, I hand over.
Thank you, Yogita. So we have the final speaker, Dr. Anchal Gupta. She's preparing with her slides. Okay. So she will be speaking on leafy grass, a novel immunomodulator. Dr. Anchal Gupta, she is founder of Netradam Eye Institute, currently practice in New Delhi, a social entrepreneur and a specialist in cornea, cataract and refractive surgeries. So she's just arrived from Delhi, just walking here. So we hope to listen from you on the new immunomodulator, the leafy grass.
Am I audible? Yes, I'm audible. So very good evening to everyone. I'm Dr. Anchal Gupta and I've just rushed my way from the airport to be here on time. So thank you all of you to be around here. And today I'll be talking about leafy graft. So the purpose of this talk is to bring forth to everyone that very soon in Indian market, we are going to have leafy graft, which was not there with us before. So that's the whole idea, that we should all now be happy and excited that soon we can use this novel immunomodulator for our patients of dry eye and ocular surface inflammation. This medicine has been available by the name Xiidra throughout in USA, Australia, Japan, but we Indians, we did not have it. So very soon, in a month or two's time, we are gonna have it with us in our pharmaceutical kitty. So we should be knowing what it is, what it does, how we can use it, and how it can benefit our patients. So I'm gonna talk about Liftigrast 5%. So it's an immunomodulator, like all of us have been using cyclosporin before as an immunomodulator in our patients of inflammatory dry eye. When we talk about inflammatory dry eye, we bridge the paradigm of the thought process that we have been thinking that dry eye and inflammation are different. No, they are not different. Dry eye and inflammation are very much the same, to an extent that I won't be wrong if I call it dry itis. Because gone is the thought process when we would think that dry eye is deficiency of tears, or it is just evaporation of tears. No, the entire mechanism of dry eye in our patients is based on underlying inflammation at the ocular surface. So we as ophthalmologists should be focused not just on providing an ocular surface lubricant, but should be really geared up to take care of the inflammation on the ocular surface. Now, what are the tools we have to take care of the inflammation? We either depend on steroids when we are battling with acute onset inflammation. But if we are dealing with a patient of long-term dry eye, we have to be prepared with good immunomodulators, which are not steroid, and hence we don't have the risk of steroid in our patient's eye, and which are safe systemically and on the ocular surface and acceptable by the patients. So we have Liftigrast. So grossly what happens in an ocular surface immune response is when the ocular surface is dry for a long time, it causes surface inflammation. The surface inflammation excites the T cell. These T cells, they produce cytokines. In the initial event, that's a good response that helps in saving us from the irritation. But if this inflammation is there for a persistent or a long time, that causes continued inflammation and hence scarring and permanent side effects in our patients. What really happens is that there is LFA1 on the surface of T cell and ICAM on the surface of the epithelium of the eye. It is present on the conjunctiva, the corneal epithelial cells and all around. In case of inflammation, these ICAM from the T cell, they come and interact with the, these LFA on the T cell, they come and interact with the ICAM on the epithelial surface. So what we have to figure out a method which stops this interaction between T cell and the epithelial surface. Earlier we had cyclosporin, but that was grossly suppressing the inflammatory system. So we were in search for something which was more selective, which was limited only to the inflammatory T cells and not the normal T cells. So liftigrast is novel in a way that it inhibits, it mimics the surface of LFA1 and therefore it inhibits the synapse between LFA1 and ICAM and hence it breaks the cycle of inflammation that happens in patients of dry eye. How liftigrast is used? Liftigrast is used just like any other immunomodulator, which is twice a day BD, and it is a preserved molecule. It will come in the preservative-free molecule, and we'll be having it in the market like a preservative-free molecule, which will be in the form of unims, which can be kept at room temperature. So, the drug has been present since 2019 in the global pharmaceutical world, and it has been well accepted. It is USA FDA approved, but in India we'll be having soon, and there has been a large blinded multicentric control study which has been done, and the study was compared with CMC and liftigraph both twice a day across the centers in the country, and it was very well accepted that the drug helped in improving the eye dryness score, it helped in improving the discomfort score, it helped with ocular surface disease index, TBUT, fluorescein screen, epithelium surface marking, and in all the expected parameters, it was better than just a BD CMC usage. So hence I conclude that, and the most novel thing which was figured out, that it has a faster onset of action. So we don't have to wait for 3 weeks in our patients. It usually shows its effects by 10 days to 2 weeks and begins to show positive response in our patients. So we can safely use liftigrast in our patients of dry eye, and it can be very much a good substitute to the existing immunomodulators where we face the risk of systemic side effects like bone density suppression and nephrotoxicity, and the drug is very much acceptable with minimal ocular surface side effects. That is me for today. Thank you so much for your patient listening.
Thank you, Dr. Anchal. And I must congratulate you for coming right on the time, and that you are. We are lucky enough to hear from you on this new immunomodulator.
I thank you, Dr. Lomi, to constantly communicate. I really appreciate. We were well communicated that okay, I can make to it. I can make to it. Thank you so much for such a beautiful organization, and also the team of Micro who was there coordinating. And also we are going to have this drug through the factories of Micro. Liftigrast will come through us through Micro.
So one thing I want to know, is there any studies to difference between the cyclosporin
No.
0.05?
None as of yet.
Okay.
None as of yet across the world. There is no comparison between
what would be the
cyclosporin.
cost? Like I have seen one cost is around, it costs around 50,000 for a month in the Western countries. So if it come to India, how? Like
Yes, that indeed is a challenge, and that is, I think we will be able to comment in a month or two, because as much as I understand, even the company has not zeroed down at what price point will they bring it. Indeed, that's a very big concern for a developing country like India.
And the side effects like
The side
irritation
effects,
and all?
yeah, the side effects so far which has been documented are occasional blurring of vision and occasional surface irritation, but
The
vis-a-vis,
taste sensation is there.
yes, the disturbed taste sensation that happens with liftigraph. There hasn't been a vis-a-vis comparison, but let's see if it fares better. It seems to be faring better than cyclosporin in longer term, and its seems to be having a longer, a faster mode of action. But yes, we'll be able to
And-
comment on that once we
And the
use it.
studies they have got that efficacy usually come in 2 to 3 weeks times, where we see in cyclosporine we see it later 3 months time. So
yes.
that's another pros from these drugs.
Yes. While I was wondering about the bad taste, I was wondering that we Indians are anyways used to tikha and teda meda khana, so maybe we accept it.
Okay.
I have a question.
Yes.
Have you actually used this drug?
No, Dr.
Okay,
Rishi, I
okay.
haven't.
Okay.
Yes. I'm sure you must have used with your
No,
patients.
even I haven't used, so I was curious how was your patient experience. So
So it hasn't come in India as of yet. I have had few of my patients who are living there in USA and they are using it. So they have mentioned that they are using it conveniently. But yes, I haven't used it in my practice. I'll be able to once it is launched. It is yet to launch.
Okay, thank you. With that, we will conclude this session. And I would like to thank all the presenters, all the co-instructors, and also all the audience for coming here and availing your time here, and all the audiovisual, everyone here. Any final comments from them?
No, I think I enjoyed the session and I'm so glad the audience remained engaged. I'll just request everybody to come for a group photograph. Then we have to hand over to the next.